the care of or how the palliative care is integrated into pulmonology patients in ICU. And we have Dr. Rajani Surendar Bhat with us, who is a consultant physician as well as a pulmonologist, and presently working at Spark Hospital, Bangalore. And she has completed her residency in internal medicine and fellowship in pulmonary diseases and critical care medicine from Albert Einstein College of Medicine, New York. She is an elected member of the Governing Council of Indian Association of Oncology, and she is a member for a program called Megatrauma Dinner in India. And her areas of interest include interventional pulmonology, interstitial lung diseases, medical humanities, palliative and end-of-life care, burnout prevention, death literacy, communication sciences, healthcare activism, medical law, and ethics. She is also active in the field of education, research, and implementation of best practices in palliative pulmonology in India. She has been helping us with various programs in the in her expertise pulmonology. And I welcome Dr. Rajani, and it's our day.
Thank you, and a warm welcome to everyone. I'm just going to share my screen. Please let me know if you are able to see my slides.
Yes, it's visible.
Okay, wonderful. So good evening and welcome to everyone who is enrolled in the Global Fellowship. Firstly, I want to say congratulations to all of you for being a part of this fellowship, and I hope that you'll be able to carry the message and work far and wide to wherever your practice has a scope to expand. So I know that there have been a lot of topics that have already been covered by eminent faculty before me. So I will dive right into my topic for today, which is palliative care in the intensive care unit, with a specific focus on patients with pulmonary disease. So just let's understand what the problem statement in respiratory diseases is. This chronic obstructive pulmonary disease is now the third leading cause of death in the world. And what is striking about some of the chronic pulmonary diseases is that there is a very high disease and symptom burden for a long period of time. So from the time that one is diagnosed with the disease, the patient is going to have a period of maybe anywhere between 5 to 8 or sometimes even 10 to 15 years, where they live with a high symptom burden. And what about control of their symptoms as the disease progresses, as the patients have a worsening of their quality of life? So even if we look at European countries which have a national healthcare system, in a study which looked at the end-of-life care in patients who are dependent on oxygen, either for COPD or for cancer, the data were shocking because they revealed that COPD patients suffered with more breathlessness, more anxiety, pain, and nausea, which was not adequately addressed in terms of palliation of symptoms. So there was less prescription of medications for patients with COPD than for patients with cancer for that large symptom complex. And this is worrisome because it means that there are a large number of patients across the world who are living with a very high burden of symptoms, which is not being addressed from the time of diagnosis and definitely leading up to the time when they are closer to their end of their life. What about other more rare but similarly burdensome diseases like cancer in respiratory symptoms like idiopathic pulmonary fibrosis, interstitial lung disease, or pulmonary hypertension? So again, here too, they found that a vast majority of patients with interstitial lung disease ended up dying in hospital. Only 1/3 of them had end-of-life decisions made. And, just 57% had, advanced directives about whether they would, about DNR orders. And a lot of those decisions were made in the last 3 days of life. Many people, even in the last 3 days of their life, went through CT scans, MRIs, a lot of blood tests, and a lot of high-end antibiotics. Up to 80% of patients were on IV antibiotics in ICUs before they died. And the majority of opioid prescriptions were in the last 1 week of life. Though these patients had probably been suffering with breathlessness for weeks to months to years before that. So when you're looking even at the patients who are being taken care of by specialists, so you look at specialists who take care of patients with interstitial lung disease or pulmonary hypertension, these are advanced respiratory failure patients. Most of them are confident about the medical management of the disease, but they are not so comfortable managing the symptoms, the burden that the symptoms places on the patient. So managing pain and quality of life issues. And many of the doctors in other fields, like my own community of pulmonologists, associate palliative care with giving up hope and confuse it to mean only end of life care. So there's a lot of work that still needs to be done, though this was 9 years ago. I think the paradigm has not changed that much, and we still have a long way to go. So overall, we are seeing suboptimal care in end-stage respiratory disease. That patients with end-stage respiratory disease, death was expected in 80% of patients in one survey, like it was in 95% of cancer patients in the same survey. But the cancer patients had been counseled about what they could expect as prognosis. They had been referred to palliative medicine. They had end-of-life discussions. Therefore, the COPD patients were more likely to die in hospitals, and they were more likely to go through invasive procedures even towards the end of their life. So somewhere we need to start shifting our approach to patients with advanced pulmonary diseases. Some of them may still end up in our ICUs at the end of their life. However, we need to incorporate palliative care early in the care of patients who have progressive advanced lung diseases. Now, the reason I bring up this comparison is that death is a certainty for all of us. Most people, if they're asked about how would they think of a good death, they would say, oh, it should be sudden. Somebody, like, it should just happen suddenly. It should be in my sleep. However, that happens with very, very few people. There will be some others who will have a rapidly progressive disease, which is terminal illness, and then there is a rapid progression, and in a very short time of a few months, it may lead to death. Whereas most other people will have some kind of chronic disease, which will lead to repeated hospitalizations, repeated drops in the organ function and overall performance status, leading to death. Or in some people, it's just old age and frailty. So when we look at chronic respiratory disease, there is a certain trajectory again that we see, which mimics these 4 roads to death that we see in anyone else. And that is usually that after the time of diagnosis and onset of symptoms, some patients who have a rapidly progressive disease may end up dropping down very rapidly. Others will have dips and some stabilization, dips and some stabilization. Still others will have an inexorable progression, which happens with a worsening of symptoms, with a worsening of quality of life. But for the most part, with chronic respiratory diseases, we are able to see the decline that happens. In some of them, we can identify a certain trigger or an event which leads to a decline. Like, for example, we noticed this in the post-COVID world, that COVID sometimes led to the unmasking of other diseases and symptoms that came up, which led to further worsening of symptoms, frequent hospitalizations, frequent use of ICUs. And therefore, the initial trigger was one hospitalization in a seemingly healthy person otherwise, which leads to a decline in their health. But it's important to recognize that in most people, more than 75% of the population we are able to recognize a decline in health, and therefore this also allows us to start conversations and start planning on how to support not just what needs to be done for the disease, but what needs to be done for the patient and the family in order to support them through this. Now, the worldwide bodies of professional bodies like the American Thoracic Society have all recognized, the Indian Chest Society, the European Respiratory Society, all of these bodies, professional bodies, have recognized a long time ago that palliative care is not something which is that a patient is having a critical illness or a progressive serious illness, and that one is giving them curative restorative care, and then at some point we say, oh, there's no point, this patient is not responding to treatment, and from that point on is when palliative care starts. That is not how it is. We know that it is a continuous process where the two aspects of curative restorative care as well as palliative care start from the time of diagnosis of this life-limiting illness. The larger role may be of curative restorative care in the initial phase of the disease. The intensity of care of curative restorative care is higher in the early stage of the disease. And palliative care, as the symptom burden is lower at that time, does not play as major a role. But however, over time, as the symptom burden rises, palliative care ends up taking a larger and larger role. And this goes beyond the point of death. It goes on to bereavement to support the family after the patient passes away as well. So let's look at what the respiratory symptom complex is. What do patients really complain about, and what is causing this huge drop in their quality of life? So it's this all-dominating symptom of breathlessness. And of course, sometimes this is because of hypoxia or because of certain breathing patterns, say a neuromuscular disease, which leads to hypercapnia, low oxygen levels, high carbon dioxide levels. Another very distressing symptom that patients experience is cough, severe, intractable cough, cough of the kind that gives you pain which is not relieved, cough which is with racking pain, which leads to fractures in the ribs and sometimes vertebral fractures, cough which is so severe and so debilitating and so embarrassing with loss of dignity for patients because of incontinence due to cough. Wheezing, a sensation of not being able to get the breath in and out. Some patients with bronchiectasis and lung abscesses may have copious secretions. Patients with neuromuscular diseases who have difficulty clearing secretions sometimes describe it as a feeling of being choked in their own secretions. And of course, there is the worry of when there's exacerbations, even when the symptoms are stabilized, there is the worry of what if this were to happen again or worsen and I'm rushed into the emergency room, I have to call an ambulance and my oxygen level is low and I'm not able to breathe. That fear that takes over, the anxiety is indescribable. And of course, they may have comorbidities. Some of our patients, especially those who have COPD, may have comorbidities like coronary artery disease or peripheral vascular disease, and they may have chest pain associated with their coronary artery disease. They may have limb ischemia, claudication pains associated with their comorbidities. They may be diabetic and have neuropathic pain. They may be having sleep disordered breathing and have difficulties with sleep related to their comorbidities. So the number of symptoms that they suffer from is pretty high. It's a pretty high burden of symptoms. And therefore, there are also the additional symptoms that one has to cope with beyond those affecting purely the respiratory system. They experience pain, they experience nausea, they experience constipation. Over time, there's anorexia and muscle wasting. Sleep can be disturbed. They have a sensation of dry mouth. And over time, they develop anxiety, depression. As they get isolated with hypoxia, unable to do more of their normal activities, they become housebound, not able to go out and participate in their social activities. And some of them may have strong feelings of guilt, especially if tobacco use was involved in the early part of the risk factors leading to the disease. There are plenty of guidelines which are available for the appropriate, ethical, medically appropriate management of end-of-life care and ICUs, especially when it comes to patients with known chronic advanced end organ failure. And these were done for the most part as consensus statements looking at evidence with, a very strict criteria of what there was evidence for and what there was consensus for. And these apply to countries across the world. I think there were as many as 51 countries participating in the Valpicus consensus statement for palliative and end-of-life practices for patients in intensive care units. In India too, the Indian Society of Critical Care Medicine and the Indian Association of Palliative Care collaborated to come out with a common position statement on the appropriate ethical end-of-life care for dying patients in the ICU. And more recently, we have had developments with the Indian Council of Medical Research's consensus guidelines on do not attempt resuscitation, as well as the recent Supreme Court ruling on yes. I'll go ahead. So recent Supreme Court ruling on decisions around advanced directives and withdrawal of life-sustaining treatment as well. So these are all promising developments, as it is a very comprehensive discussion that needs to be had about the dilemmas and complex ethical questions that come up, which actually involve not just medical technical competency, but also competency in principles of ethics and principles of understanding values, and in a high level application of communication of the patient's medical clinical condition to patients as well as their caregivers and surrogate decision makers. We see that there seems to be, even though guidelines have been in place for about at least a decade and more, we still see that there is a gap in terms of inadequate referral to palliative medicine, despite availability in some areas. We do understand that palliative medicine specialists are still not as many as we need in most countries. It is a specialty which is most populations across the world are underserved when it comes to palliative care. However, even when existing services do exist, are available, one sees that there is late referral to palliative care. So sometimes palliative care is called in at the time of ICU admission, even in patients who have had a known disease, which is life-limiting for a long time. And many of those patients, once palliative care teams go in to see them, one realizes that the burden of symptoms was high enough for a very long time and that they should have been called in sooner. Now, this is a real problem, because if palliative care team is called in at the time of an near fatal situation in the ICU, there is no time to get to know the patient, build a connection and a relationship and a rapport with the patient and their family member, and get to understand their values and what they want in terms of their goals of care. Because it sometimes is perceived by the patients and the families as giving up by the primary clinician team. It sometimes is experienced as perceived as abandonment by the primary team. So it's very important that, especially in patients with chronic lung diseases, one starts the conversation with the palliative medicine team or integrates the palliative medicine team's input in advance, while the patient has an observable objective decline in their pulmonary function or their performance status or their ability to walk or their dependence on oxygen or any hospitalization which is not for a critical illness. If one gets involved in their care at that time, then we are able to truly make an impact on the quality of life of those patients towards the end of their life. And even if they do end up going to the ICU, at least one is able to make sure that the goals of care are paid attention to, and the care that's provided to these patients is aligned in terms of values. Palliative care is not just about having a DNR conversation. Unfortunately, this has become the understanding of some people that I'm calling a palliative care consult to stop certain medical services for a patient or to declare them to be DNR. Now, communication is a skill, or primary palliative medicine is a skill that all medical professionals should have. We ideally would want it to be that palliative medicine is called in when a patient has a high symptom burden or a symptom complex where the requirement of palliative care is higher than a single symptom which may be managed by a primary, at a level of a primary palliative care knowledge as well. So it's important that we understand the distinction between palliative care and end-of-life care. As it seems like a lot of people call in the palliative care consult in the ICU only to have these complex conversations about advanced directives about end-of-life care, and very often misunderstand the real focus of palliative care, which starts from the time of diagnosis as disease progresses, includes end-of-life care, includes reduction of symptoms even during critical illness, and continues after the death of a patient. So it's important that we understand what are the distinctions in these terminologies. What is CPR failure? What is brain death? The difference between palliative care and end-of-life care we don't call in palliative care for a brain death declaration, or when a patient is, we call in palliative care way before it is about making a patient DNR or something like that. There are certain misconceptions that people have about withholding and withdrawing life support. There are arguments to be made about which is easier for patients and families to acquiesce to or choose. That being said, ethically and legally, withholding life-sustaining treatment and withdrawing life-sustaining treatment are considered equal in a matter of ethics or in a matter of medico-legal parlance. Euthanasia is a word that is used often. In literal translation, it means good death. However, though it is used in legal terminology in India, it is not a word that we prefer in medical parlance, because in medical parlance, the better terminology is to allow natural death. When we say we are opting for palliative medicine to come in and opine, it is not to euthanize a patient. We are not doing anything actively to facilitate or hasten the process of death and dying. We offer palliative sedation in order to relieve any symptoms or distress that a dying patient may experience. This is done with doses of medications being titrated only to achieve the effect primarily of alleviation of symptoms. We also understand the doctrine of double effect, where the side effect of the medication which is used to alleviate breathlessness may also cause changes in respiration or hemodynamics, which may eventually lead to death. But the goal is only alleviation of symptoms. It is not to hasten the process of death and dying. It is primarily to relieve the symptoms. There are larger debates that are on about physician-assisted suicide or medical assistance in dying, which is not practiced in India. There are many countries where medical assistance in dying is legal. And that's beyond the scope of today's discussion, but I just wanted all of you to be familiar with these terms, the terms which are medically appropriate and the other terms which are sometimes bandied around, like passive euthanasia. There is no such thing as passive euthanasia. There is only active ethical care of a patient. So if I withdraw medically inappropriate or non-beneficial treatment, that is not passive euthanasia. We also don't like using the language of futility. There's nothing like futility. It is about recognizing what is medically appropriate or what is non-beneficial for a certain patient in a certain situation. based on the evidence available for treating that condition. So as you can see, there is a real barrier to implementing good high quality palliative care in the ICU for our patients with pulmonary diseases. It's a complex situation. We haven't had enough discussions about it during our formative medical training years. People think of palliative care as a nice to have service, not a necessity. Cultural acceptance of palliative care still has a ways to go. For most part, people think of palliative care as pain management and cancer care. So these are all barriers that we need to overcome in order to incorporate more palliative care practices which are ethical and medically appropriate in ICUs. Patients with pulmonary diseases suffer a lot of distressing symptoms, as we discussed earlier. There is pain, there's a lot of breathlessness, and there's thirst. Now imagine a patient who is in an ICU for acute on chronic hypercapnic respiratory failure. That patient may be on non-invasive ventilation or a BiPAP mask initially for 24 hours a day, then maybe getting just 1 hour breaks without the mask. Over time, they feel a lot of pain around their nose and mouth. They feel pain around their head from the straps. They feel pain from being in just one position and getting breathless from just trying to turn position. So they are so limited. The physical constraints of their disease itself causes so much of pain and discomfort for them. Many of them will be NPO for procedures to be done, or they may be considered risk for worsening and intubation. So therefore, they may be nil by mouth at that time. So they also have thirst. They are in an alien environment. The lights are on all the time. There are sounds that are there all the time. Their sleep is disturbed. Some of them may be receiving medications like steroids for COPD exacerbation. All of these can also lead to ICU psychosis, agitation, and delirium. If they are on a ventilator with an endotracheal tube, or if they are with a BiPAP mask, they're not able to speak and communicate. So therefore, they are in greater distress at that time. Their family members who come in to see them are completely distressed seeing them in that state as well. So this is sort of a cycle that feeds off itself. Both the patient and the family member caregiver are unable to cope with the acute critical illness that's there. So along with medical intensive care, what they also need is intensive caring support to help them to help them overcome the barriers of communication. So using communication aids, just a simple, a board which has the symptoms with parts of the body on it, pain, itching, cold, hot, and a body map. And then so that the patient can just point out what they are experiencing could make it so much easier for nurses, doctors, family members to communicate with patients. So when they go through breathlessness, many of them have been experiencing breathlessness for a long time. I'm briefly going to talk about breathlessness and the ways of coping with it in patients with chronic breathlessness before I come to the specific point of ICU and dyspnea breathlessness in the ICU. So it's important that we understand that breathlessness is a very multi-dimensional symptom. There is a huge component of it, which is in addition to the physical component of your lungs, heart, hemoglobin level, neuromuscular strength, alertness, all of those contributing to breathlessness. There is also the concept of anticipatory pain, anxiety, all of that contributing to breathlessness as well. Now, this will be heightened further in an ICU because an ICU is a scary place to be in. So their anxiety and stress levels are already high. There are more thoughts about what if things get worse. And therefore, the anticipatory breathlessness is already ramped up much higher when they get admitted to an ICU. When we think of functioning, the fact that if you are breathless, you exercise less, that leads to more muscle deconditioning. As your muscles get deconditioned, then you get breathless with the slightest activity. So one of the most important pieces in the management of breathlessness and patients with chronic lung diseases is pulmonary rehabilitation. Now, I recently had a patient who is awaiting a lung transplant for advanced interstitial lung disease. And he had come into our hospital in November of 2022, completely bedbound, breathless, even on the slightest effort of sitting up from lying down position. We optimized his volume status. We optimized his medications. He was discharged from the hospital and he was on pulmonary rehabilitation at home and had gotten to a point where on 4 liters of oxygen, he could walk from the bedroom to the living room, spend the whole morning and afternoon in the living room along with his family, even play caroms and cards with his family members. And this gentleman recently got COVID. Now, what happened was when he got COVID, because he already had an underlying condition of interstitial lung disease and chronic liver disease, he was severely affected, needed medications, was in the ICU for 5 days to receive his medications. And in those 5 days, there was a period of deconditioning that happened. So imagine patients who are in longer periods of time in the ICU. Sometimes we have patients with COPD who may end up spending as much as 2 weeks or 3 weeks in the ICU. If we aren't taking care of the rehabilitation in the ICU, they get more deconditioned, and then their experience of breathlessness is worse. So therefore, it is important that for patients with pulmonary diseases, who especially those who are receiving pulmonary rehab at home, that we continue to allow them to do their exercises or actually facilitate it with physiotherapy, even when they are in the ICU, so that we don't lose the gains that we have made in their symptom control. Now, one point here is that while we encourage them to exercise, in pulmonary rehab, our goal keeps shifting in these patients with chronic diseases. We're doing the same exercises to keep breathlessness under control. Once they stabilize and are much better, then we increase the intensity of the exercise to help them build up a little more strength. So the same exercises, your goal may be strengthening or it might be symptom control, but the idea is to keep going in the ICU, that which allows their breathlessness to remain under control. What if things are getting worse and none of this is helping their breathlessness? Treating the primary condition, providing them with oxygen support, NIV support, giving them diuretics, steroids, antibiotics for any infection. And if this patient is progressing and then develops refractory breathlessness, then low dose sustained release morphine or immediate release morphine as well in divided doses have a great role to play for breathlessness. Benzodiazepines also have a role to play with refractory breathlessness, because that experience of breathlessness that I am not able to breathe and I might choke, or I feel like there's someone squeezing my throat, or I'm drowning, that is a devastating experience. So it is very important that we not hesitate to use opioids, low dose opioids and low dose benzodiazepines to address the breathlessness of patients, whether it's in the wards or in the ICU, those patients who have a chronic progressive condition which is advancing. People worry about carbon dioxide levels rising. When you dose it correctly, you rarely see a significant rise in carbon dioxide levels. One rarely sees any fatal side effects happening from the use of low-dose benzodiazepine and low-dose opioids. Observe that I keep stressing on low-dose, low-dose. We have seen side effects, including some potentially life-threatening side effects when higher dose of benzodiazepines are used. So when I say low dose for breathlessness, the dose of morphine that we use is typically anywhere between just 5 to 10 milligrams, 3 to 4 times a day is usually adequate for most patients with breathlessness. So when rarely using more than 10 to 30 milligrams over 24 hours for breathlessness. So these are much lower doses than what one uses for chronic refractory pain, as you can see. So these doses do not have as significant an impact on carbon dioxide levels or respiratory depression or any of those things that traditionally we used to be worried about. What about certain special situations that we need to address? Is that Sometimes patients have a known progressive illness, but sometimes there is something which progresses very rapidly. So maybe we've not had the conversation. So you may be a pulmonologist or a physician who has a patient where you've just made a diagnosis. It's an early stage in the diagnosis of an illness. So say, for example, if it's an interstitial lung disease, or it's an early stage diagnosis of a lung cancer, and suddenly something happens, like a severe pneumonia happens, or people who went through influenza or COVID-19 recently, where there was rapidly progressive viral pneumonia and they developed ARDS. So you've not really had a chance to have the end of life care discussions or have the advanced directive discussions. In these situations, it always becomes harder. It's more of a dilemma, the kind of decisions that one has to help the family facilitate. It's very different from advanced progressive respiratory disease, where we are able to provide them with a plan of care for acute emergencies in that situation. So keep in mind that the rules of engagement will be slightly different when it comes to advanced progressive disease, which is known, and then there is an acute emergency, whereas a recent diagnosis with a sudden worsening. So what are these acute emergencies that we typically encounter, which lead to rapid deterioration? Sometimes it's something like aspiration pneumonia. It could be a person with a known lung disease, and then they have, say, a neurological event and then an aspiration pneumonia. And since you already have compromised lungs, the second insult is not something that the body is able to take. There could be worsening type 2 respiratory failure, so acute on chronic type 2 respiratory failure. Patients who've been on tracheostomies with a lot of secretions, with neuromuscular disease and pulmonary involvement with neuromuscular disease can have this kind of a situation with blocked tracheostomy tubes. And in this situation, the progression of symptoms and acuity severity of illness can be pretty rapid. Therefore, it's important that we have some discussions of who are the patients in which I think it's an important thing to have prior discussions. Any patient who's going home with a tracheostomy, any patient who is requiring more than 8 to 10 hours of non-invasive ventilation at home, any patient who has started developing problems with swallowing, who has problems with aspiration. These are patients where we should have some discussions early on, so that if they get admitted with critical illness, it is easier for us to facilitate the decision making for the family in these situations. High flow oxygen is an option which is being studied a lot more, and especially for patients with chronic respiratory failure who have made a decision that they do not want to go the route of intubation and mechanical ventilation. High flow oxygen gives us an option which is far more comfortable and allows us to tide over some acute emergencies without resorting to ventilation. So while the role is much better defined in interstitial lung disease, the role is still being studied and evaluated in type 2 respiratory failure and COPD patients about the role that high flow may have to play when they come in with exacerbations into the ICU. So whenever they come in with this acute worsening, and especially in that situation where I was telling you about, diagnosis has happened recently and you thought that there was more time for discussing the options available and what the path of the disease might be. This is the situation where it's very important that we keep in mind the principles of medical ethics, where we keep in mind that autonomy, beneficence, non-maleficence, and justice are to be kept in mind. Along with this, I think it's also important to keep in mind that we are not just technicians who say this is the disease, these are the options. So we don't offer them options in terms of a cafe, but we help them make informed decisions, well-supported decisions. And in this situation, we must balance what the truth of the situation is without completely abandoning all hope for the patient. So these are tricky balances to maintain, but as long as we are guided by the 4 pillars of medical ethics, we are able to help patients and their families come to decisions about their critical illness, which is more aligned with their own values. One more very distressing symptom, I'm sorry, I think my slides got a little out of order, so I'm jumping gears over here a bit, is when patients have this very distressing symptom of hemoptysis, when they have lung cancer or drug-resistant tuberculosis or a pulmonary embolism or severe pulmonary hypertension, and they're having massive hemoptysis. It's very, very distressing, and it can be an acute emergency which has patients land up in ICUs. So the important thing here is to give cough suppression, stop oil nebulization. We can give tranexamic acid. Using a low dose sedative is important to cut out the distress that patients experience with seeing their own blood spattered about. Any further intervention depends on the goals of care. And one very simple tool to keep is to use dark colored linens. Can you imagine the sight of red blood over white linens? So even if just the use of dark color linens can help to reduce the anxiety that the patient is experiencing at that time. For neuromuscular diseases, aspiration pneumonia remains the most worrisome progression with involvement of the respiratory system. So there are well described criteria for how do we evaluate patients with neuromuscular diseases and when is the risk of aspiration high, so that we can advise them to go ahead for a percutaneous gastrostomy tube to be placed. The important thing here is if we wait too long, then they've already suffered from some degree of nutritional loss and muscle wasting and cachexia, and are more prone to illness and repeated infections already. So the ideal thing would be when the patient's swallowing is affected, their food intake has come down, or if they have had a few episodes, have had an episode of aspiration already, or if they are able to perform lung function tests, if the FVC falls below 50%, and then that is time for us to start monitoring very regularly to see whether we need to place in a PEG early enough. A PEG will not reduce, when you're looking at a choice between a Ryle's tube or a PEG, a Ryle's tube will probably have a little bit more of reflux and aspiration that can still happen. So I don't really prefer that. If we make a decision, of course, as a temporizing measure, a Ryle's tube is fine. But since these patients with neuromuscular disease will have a longer duration of time where their mind is completely engaged while the body is slowly getting weaker, it's better to have decisive discussions with values being discussed and then either decide for a PEG early, or if the patient's family chooses for no artificial feeding, then helping them understand that we are there to support them with any symptoms that come in line with that decision as well. So we took a detour on aspiration pneumonia and hemoptysis. We were discussing ethics. So like anything else, the clinical practice of ethics in the ICU requires some degree of deliberate practice. So while we've studied it in theory, every time we go over these decisions about why we are suggesting something or offering certain choices to patients with critical illness in the ICU, it's a good practice to think about it in those 4 boxes of preserving patient autonomy, of doing what is right and good for the patient with beneficence, not offering them any treatment which could potentially cause harm, and also keeping in mind in our situation, we're a low resource country, for judicious use of high level care, especially only in situations where we expect that it is in alignment with the patient's values and is likely to give us a good outcome. There have been, as I said, promising and heartening developments in the reframing of the law, which helps us to improve the quality of end-of-life care decision making. Some pioneering work by Kasturba Medical College with the Blue Maple Protocol, which helps in helping with algorithms that one can use in intensive care units to provide better palliative care in intensive care units for patients with various types of end organ diseases, not just pulmonology, but this particular Blue Maple document actually gives us a blueprint of sorts, an algorithm of sorts that we can follow for critical neurological illness or heart failure or liver failure or kidney disease, as well as for respiratory failure. Uh, Ideally, we would want a model of care where the palliative care team is part of the ICU team and involved in rounds from early on. If that's not possible, then now with telemedicine being available, I would urge all of you who are in this course to influence your administrators at whichever institute you are at, that if there isn't a palliative medicine service, I'm sure you're going to be the pioneers who will go implement it wherever you are. But as a start, the other model to consider is a telemedicine option of providing palliative medicine consults for critically ill patients in the ICU, where there's difficult decisions or complex symptom burden that needs to be addressed. What about end of life discussions? So sometimes we have patients coming in and then they go in with acute illness to the ICU and make it out of that particular episode. I think these are opportunities for us to open conversations with these patients about what to do if they fall seriously ill again. Ideally, we would want these conversations to happen before any first ICU admission as well. Just if they've had more than one hospitalization in the last 1 year with older patients, if they have multiple comorbidities, if they're experiencing weight loss and you can see that they're, cachectic, their appetite is down. These are all things, if they're dependent on oxygen, these are all things that lead us to ask ourselves that would we be surprised if this patient did not make it past this year? And if the answer to that is yes, I would not be, if the answer is that I would not be surprised if this patient didn't live to see the next year, then we should be talking about what would the patients prefer if they get sicker. So just asking them, like, have you ever thought of what to do if the disease gets worse? Some of them will share about experiences of their relatives and friends. Oh, I had an aunt and she had this disease and she was in the ICU in the hospital for 1 month before she died. I don't want that to happen. So there's open-ended questions which can, where do you think people should spend their last days? And you don't say, but you ask them what they think. Most people will think that the last day should be spent at home. So that allows us even to make the plan for acute emergencies in patients who have advanced lung disease. The other limiting factor that comes up sometimes is what kind of care is available. So sometimes patients' care needs are very high. And in this situation, sometimes they will opt for care in the hospital also, depending on their financial situation. Cost is a prohibitive thing for some patients. Depending on the model of healthcare in any country, whether it is nationalized healthcare or whether it is out-of-pocket expenditure. That is one of the limiting factors. And after that, it's about the availability of supporting nursing services for these patients in the home environment versus in hospital environment. So all these decisions about being admitted or staying at home, if admitted ward versus ICU, if admitted in the ICU, use of non-invasive ventilation versus high flow nasal cannula, all of these have an impact on the experience of the patient as well as the caregiver about the quality of death. So we know that the quality of death for most people is perceived to be better if the patient is able to be supported at home, if not in the hospital, with adequate palliative care, with control of symptoms of breathlessness, pain, agitation, delirium. In case of patients who require oxygen support, high flow nasal cannula is a better option than NIV in any situation like this. And of course, offering support to the family members after the death of patient with at least a few follow-up visits to check in on them and see how they're doing is advisable. So this is what, at the time that the patient gets admitted, it is important. One of the questions that comes up often with palliative care in ICU for patients with pulmonary diseases, family members are worried about what they might witness. So it's always good when you're taking a family member in to prepare them for what they may see when they see their loved one in the ICU, that they'll see tubes and things. They want to know whether they are comfortable or experiencing any pain. Can they touch them? Can they hear if I speak to them? So it's important that we share with them that even though they may be on some medication for sedation and for comfort, it's perfectly okay to touch them. Just take care of infection control practices. It's perfectly okay to speak with them while they may not respond to you. They may still be hearing you, and at least what they will feel will be the presence of loved ones around them. Um, Help them to resolve non-medical issues and encourage them to do that when they are when it seems imminent that the patient is having progressive disease. So what people are looking for in that situation when they are close to, when death is imminent, is some kind of closure. And even in patients in the ICU, especially pulmonary patients in the ICU, they will have periods of drifting in and out of wakefulness. But in their moments of wakefulness, if we are able to help the family, give them a sense of closure, that they have lived a meaningful life, that they are able to remember important milestones in their life with fondness, and if they are able to let go of any regret that they may hold, or achieve closure with any family members, or be able to listen to a favorite song, or maybe see the face of a grandchild or something like that, then we are able to provide them some degree, some measure of comfort even at the end of life. And I leave you with a couple of thoughts. This was a story shared by Dr. Wes Eli, who is a critical care chief in a university, I think it's Vanderbilt, and he had this patient who had severe COPD. And as you can see from this image, he has a tracheostomy in place. Now, this gentleman had severe COPD, was oxygen dependent for, I think, 2 or 3 years before this particular hospitalization. And he was intubated by paramedics in his house when he was unresponsive, brought to the hospital, placed on a ventilator, could not be weaned, underwent an early tracheostomy, and subsequently was still not able to be weaned over a prolonged period of time. And at some point he said, "This isn't what I want." And he wrote and told his doctors that what I want is a nice cold beverage and my wife to be sitting next to me holding my hand, and I think it's time for me to face the inevitable. And what they did was they extubated him. They made sure that he had an infusion of low dose opioids going on. They gave him the beverage of his choice. You can see on his fingers, he even had his beloved's name tattooed onto his fingers, and he's holding his wife's hand, and he drifted into a sleep that he did not wake up from over time. Very often we are so obsessed with the numbers that we lose sight of what the patient wants out of life. So the question that we ask is not, what is the matter with you, as in you have severe COPD, which is gold this criteria, or the PCO2 level is 78 and the pH is this. But what matters to the patient, what mattered to him was that he was ready to meet his end with his wife by his side. So I've shared a few quotes by famous doctors, by Sir William Osler, about understanding, knowing the man who has the disease rather than the disease that a man has as well. I think this could be a modern version of the oath that we take, where we say we will remember that we don't treat a fever chart or a cancerous growth, but a sick human being whose illness may affect the person's family and economic stability. And our responsibility includes those related problems if we are to care adequately for the sick. ICU care is an expensive exercise. So it's very important that if we incorporate palliative care early for pulmonary patients in the ICU, we might also offset the financial toxicity which sometimes brings some families to ruin. I leave you with images of some of my patients who are no more, but who we were able to help on the journey over 8-10 years as they faced and walked along with chronic respiratory illness. And they had visits in and out of the ICU, but each visit was accompanied by careful discussion of the goals of their care. And when one patient, the painting that you see on the left, that gentleman chose to go home and meet his death at home, in his home, surrounded by his grandchildren. The other gentleman chose to move from the ICU to the ward, still surrounded by his family in the ward, but he wanted greater support for the nursing care needs that he had, which he felt would be burdensome for his family. So whatever be the choice the patient makes, I think the important thing is preserving their autonomy, making sure that whatever line of treatment we choose is beneficent to them, that it's not doing them any harm, and it's the appropriate utilization of resources, and supporting the family and caregivers through the entire process of critical illness, progressive advanced respiratory disease, and death and dying after that as well. Thank you.
Thank you, Dr. Rajani. So, um, in palliative care, or whenever we talk about integration of palliative care in the subspecialty, all the time we hear what matters to you. So that's the most important question that we should ask to everybody. So I think we can open the session for discussion.
I see a question there. Is there any predictive models of short-term mortality available at present? I think it's a very important question. We have a lot of predictive models that have been put forward. For interstitial lung disease, there is a GAP score that's used, which looks at gender, age, and physiology. For COPD, there's a decision tree which looks at the indicators that I shared, which is an FEV1 less than 30%, the use of oxygen, comorbidities. One of the best performing indicators, rather than complex calculators, if I may, of predictors of mortality in more recent studies has been the surprise question that I shared with you. So the surprise question with an experienced clinician or an experienced respiratory care nurse has a very good predictive value. So I would encourage most people to just read up a little bit more about the surprise question and its value. Usually, when you ask a pulmonologist, a physician, a respiratory care nurse, a community health nurse who's going and visiting the patient at home frequently, they get a montage of the patient's life and the progression of the disease. And then they'll tell you, like sometimes they'll come back from a home care visit and say, that was not looking so good. I don't think he's going to last beyond 6 months or 1 year. That's a powerful predictive tool. So rather than other predictive models, which I would say that the surprise question surprisingly has performed better than many other physiological and measurement-based predictors of mortality.
So there is one more comment in the question. In many private hospital procedures, even not prepared, are done in ICU, unfortunately. How to bring a change in those efforts?
So I think it's a very important question, Dr. Farooq, but one of the challenges that we face is that the majority of people who do these unnecessary, non-beneficial procedures, right? I used the term medically inappropriate or non-beneficial procedures, are doing it from a mistaken notion of defensive medicine. If later the patient will come and say you didn't do it, it's usually this. So two situations that I see often enough. One is defensive medicine, where you're saying that the patient and their family member will come back and tell me later that I didn't do it and sue me. The second is a lack of um, awareness about the change in laws about withholding and withdrawing life-sustaining treatment. So a lot of people believe that DNR is illegal, or advanced directives are illegal, or things like that. Now, even the language we use, I think it's actually traumatizing to patients' family members when we, some people will write in hospitals like, patient's family does not want intubation. It makes them feel guilty, that the doctor says intubation is necessary to save my mother's life, and I am writing, I do not want, and now sign here. So you're putting this tremendous burden of guilt on a child who's about to lose their mother. So instead of that, just changing our language and saying the patient's family would not want invasive life-sustaining treatments, right? I don't even want to use the word, let me say does not want. The patient's family chooses optimal palliative medicine measures. And yeah, so that's a good choice of words. And you can also write that life-sustaining measures would be medically inappropriate, as the burden of symptoms would be much higher than any potential benefit. Right? So if you write that instead, it doesn't put the blame on the patient's family, like they signed their loved one's life away, or you have family members saying they pulled the plug. You don't want these to be the words they carry. Dame Cicely Saunders said, the way we die lives on in the minds of those we leave behind. It's so true. We carry traumatic stories of the death of our loved ones in our minds and bodies for years. So if anything we can do to make that time that they are in the ICU or at the end of their life in the hospital a little bit more, let the interactions between doctors and patients and their family members be a little kinder, just in our language, in the way we offer these choices to them. So yeah, I think it's a lack of awareness. I think it is defensive medicine. I think it is that we haven't been taught to deal with, or we've been taught that not doing something is giving up on a patient. I don't think it is giving up on a patient as long as I'm providing adequate palliation of symptoms, right? And if I'm well justified as a medical choice. So then there's no guilt, then there's no feeling of I have not done the best for my patient. What about legalities when we change the terminologies and document it? So there is, again, very good question here. What I would want you to be aware of is that in the entire, I think most participants are from India. So I'm going to address this from the Indian perspective. Laws are different in every country about withdrawal of life-sustaining treatment and things like that. The only court cases so far have been hospitals which have been taken to court because of prolonging life-sustaining treatment when there was no hope of recovery. So famous cases are a child in a hospital in Delhi NCR region, one in Kerala, and another more recent one. The hospitals were penalized for continuing ventilation or ECMO longer than there was any hope of meaningful survival. There are no documented cases in the entire Indian legal system of a doctor or a hospital being taken to court for stopping non-beneficial treatment, right? What we end up doing this is Dama or Lama. We send the patient Dama or Lama. Now, even if we are sending a patient Dama or Lama, are we giving them the palliative medicines needed for comfort on that journey? They are going in an ambulance with an ET tube, which is surreptitiously removed from the ambu bag somewhere. They are not given the support. It's so traumatizing for the patient's family members. So if we just accepted that this is part of good medical care, I think the changes that have come about right now are, as I said, promising. There's still a long way to go. Keep in mind, all of us can do this without fear as long as you have family consensus. So if there is consensus in the entire family, all children, all loved ones together, everyone agrees that this is the right medical decision for the patient, you will not be in trouble. If there is no consensus, if there is conflict, if there are different opinions, then I perfectly understand the defensive practice of medicine, because our medical legal systems are not yet mature enough to help us. And sometimes the process is as much of a punishment. But where there is consensus, there is no excuse for us not to be kind when someone is about to lose their love.
Ma'am, I have a question.
Please.
The topic which you have covered today is very close to my heart, because we take care of the ICU and we are, going through this every day. But this is about, I had a very close friend whose father was in Delhi NCR, who had multiple myeloma, and he was in the last stages. This is a case the other way around, when the patient and the family are fully cognizant of the fact that we do not want to go further. We want this patient to go as, peacefully as possible. But the doctors are like, we cannot give pain medications because it will cause, his kidneys are already bad. So this patient is, so we'll be doing wrong to this patient. So it is not medico-legally, it is not possible. So we cannot give this. We cannot give morphine. We cannot give NSAIDs. We cannot give this. And we had to talk to them, do everything. And there's a very reputed high-end hospital in Delhi NCR. I don't want to take the name. And despite our best efforts, the patient died in pain. And it was very traumatic. We are still undergoing the trauma. So what happens when it is the other way around? How can the patient
I'm so sorry, but this is again all too familiar a story. Unfortunately, in such situations, believe me, I have to advise family members or friends and family in other cities.
Yes.
What I end up doing is I find a palliative medicine provider in that city who can source the medication, and I literally get the patient out of Dama. There is no other way out. We have a huge task ahead of us to educate our own community of medical professionals that it is never medically wrong to give morphine to a person in pain who is suffering from a critical illness that they're not going to recover from.
He's a 90 or 88-year-old man, no NSAIDs, no, and this is one of the biggest hospitals in the country.
I'm so sorry.
And we are still going through that thing.
Oh,
so how does
believe me, I don't have answers for you, but I completely share in your pain, because this happens to me on a very routine basis, that I will receive a consult request from another city saying, try and find me a way out of I mean, I have had patients who've had ulcers in their mouth who've not even been given a basic local analgesic for the ulcers in their mouth.
Exactly. The patient screamed and died in pain. And they actually told me, can we take him out, Lama, and can we go to some palliative place? So, what advice do you give in a different city? As in, it's very difficult.
So my one suggestion is that, the Indian Association of Palliative Care and Pallium India are both resources that you can reach out to connect with palliative medicine providers from across the country. Right? They actually are building a directory of providers everywhere. And this has been the one thing that's helped me with some patients. So I've experienced exactly what you said with a family member, a really dear friend's father in Bombay. Again, very famous hospital, 5-star, all of those things. 5-star consultants taking care of the patient.
Yeah, exactly. And they had a battery of consultants taking care, and the most basic things.
In the end, it was about getting the patient out against medical advice, calling Romila Palliative Care, and having Dr. Antrim there take care of the patient for the last 48 hours. So I was able to get comfort care for the last 48 hours at home. But the only way of doing this is going to be by building a stronger network of people who are trained in the basic principles of palliative medicine across the country. And we go out and talk aggressively about intensive caring to intensive care specialists.
Too much of intensive care going on. Unnecessary.
Yes, intensive caring now. That's what we need.
Yes. And I would like to tell you a smaller story, that we are a very small hospital in Dehradun. And we managed to do things in our smaller hospitals, providing opioid at the last, few days, allowing the patient's family to stay. And in 5-star hospitals, it's not happening.
I think we have the good and bad in every place. I've worked in the Delhi NCR region as well, and even during COVID, sometimes we found little oases, right, at a time when some hospitals were not allowing loved ones, and people were dying with none of their loved ones beside them. There were a couple of smaller known, not so famous hospitals who were saying, your loved one's not going to make it, so we'll get you in with PPE just so you can hold their hand and they're not alone. So there were people doing that too. So you will be that shining beacon in Dehradun. Thank you for that.
Thank you, ma'am. Thank you. This was very close to what I felt. That's why I wanted to share.
Yeah.
Thank you.
I think we should ask those friends and relatives to ask for palliative care.
Yeah, I think as you say, Sunil Kumar sir, this needs the awareness in the community. Just like we think of, it is the patient community which is going to demand it, that will make more hospitals, make sure that there is a palliative medicine department in each hospital eventually.
Pardon?
Yes. Good evening, ma'am. I have one more question. What to do when you're a junior in the department and you have to convince your seniors there is something palliative care and this is not right and this is right? Because many of the times even I have experienced, they don't hear you out.
True. It's always difficult when you are in a position of not being the final decision maker. All one can do, Parul, at this point is to make sure that, as you said, you bring to their attention certain statements that I think that are very important. It's one thing is, rather than sometimes just showing papers, right, or saying, I want to present this in journal club, and you present the position paper and have a discussion on it. Then every time, the next time it comes up, but we had that in journal club, right? You can bring that up. People will always, what about you saying, but it's not the same, but at least you have raised the point. So I think in all these challenging situations where we are sort of pushing the envelope and trying to lead the actual practice, when we were talking about the no-do gap, right? There will be naysayers, there will be people who think there are more obstacles than there are. We can push up to our level of power and our pay grade, with the knowledge that when you become a senior, you will not do the same and you will keep a more open mind to more progressive ideas that come.
That's what I just think that to reach to that level of seniority, like I cannot sit and wait to reach
No,
to
you
that.
can't. So that's the reason why I said that what you can do is advocate for greater awareness even amongst your colleagues. When you say that I want to discuss and present this topic and I want to present it from this point of view, we will all have stories. All of us who practice in any intensive care kind of setup will carry a lot of stories where we have been unhappy with the outcome because we felt the care was not optimal, or something was, something was non-beneficial, some unnecessary surgery was done, something like this will be there. It matters that, one, you should constantly feel that pricking pain when you witness it. Second, that within your sphere of influence, you keep expanding other people's acceptance of this idea.
I'm trying to do, ma'am. Let's see. Thank you so
All
much.
the best to you.
Thank you so much.
Dr. Yadav has a comment. He says this happens everywhere. The following is one of the messages I got from a friend yesterday. The message is like this: recently, a friend's father passed away. She said he was in too much pain. I was wondering whether the palliative care is still not good enough in Kerala.
It's a sad state of affairs in, I think one of the things is that Kerala, Telangana are two states which have higher access than most states to good palliative medicine care in the community level. Other states, it's challenging. It's only available to some cancer institutes more than anything else. Satyanarayan and Raju, so you said maybe NABH should do something about it. To some extent they have. It's just a checkbox thing. Pain scale is documented. That's all it is. We document it as papers. Are we really applying it in principle? Are we implementing it at the bedside? I think the start has been with the EdCom modules or palliative medicine, at least as a module being introduced at the MBBS level. What we probably should be advocating for is that there be some amount of exposure to palliative medicine training at every level. So if it is MD medicine, MS general surgery, MD OBGYN, MD pediatrics, they should have palliative medicine come and mandatory question in all their. So this is the kind of thing we are advocating for. Now they have to study the basics of palliative medicine, no matter what specialization. Every MBBS person has to do it. Every other specialization, one question mandatory in their final exam will be based on palliative medicine, relevant to their specialty. Unless that starts happening, this is I'm just being honest about the state of our country. Nobody reads it unless it's coming in the exams.
Yeah,
a hospital will do it just because it needs to check box, right? Fall risk assessment, pain assessment, it's part of nursing notes. Which doctor is doing it? Nurses are forced to do everything, which is supposed to be our responsibility as well. It'll need all of us to turn into crusaders, and I hope that all of you are up for the challenge.
Anybody else have any more comments or questions?
So I think it's important that all of us get comfortable using some of these medicines safely, right? And if it's not available at your center, wherever you are, whichever city you are in, whichever hospital you're practicing in, find out where you can source it from. I was at a hospital where I was able to prescribe outpatient morphine. At the place that I'm practicing at right now, I can only dispense opioids inpatient. So we've found our ways around the system. I've built my network around my locality, my small locality in Bangalore, so that I know how to get it legally and correctly for our patients, and our hospitals work well. So each of us can be little champions. Just get comfortable with using the medications and following the recommendations for alleviation of all these symptoms.
If there are no more questions, I think we can wind up the session. And so today we talked about the reality of what is happening to not to the patients, to our friends and relatives, and to us. So thank you, Dr. Rajani, for that thought-provoking presentation. And
Thank you for inviting us.
Shripriya, so
Thank you, Dr. Rajani. And I am personally relieved that you didn't take up that breathing exercise, because that would have startled me.
Well, this was in the ICU, Shripriya, so I didn't go in for breathing exercises for patients in the ICU.
Thank you so much. I know that you might have had a busy, tiring day as any days, but you found out time finally to join us and walk us through the session. Thank you so much for that. And thank you each and every participant. I could see some of our participants are also undergoing the future faculty training as well. And they might also be damn tired for the day because they have been traveling through this from 3 p.m. So thank you everyone for joining in, and let us hope that the mission we are on to make palliative medicine reach where it is needed keeps on going. So with a promise that I will be meeting again tomorrow with another topic and get a remnant faculty. And please do note, tomorrow's time is 6:30 p.m. This is Shripriya along with Dr. Rajani Surendar Bhat and Dr. Sunil Kumar signing off from the Palliative India's desk. See you again tomorrow. Till then, everyone, take care. Bye-bye.